All right, so you have the floor.
Okay, let's see what I can do here. So I'm sharing my screen. And we're going to go to view, we're going to go slideshow. Okay, is everyone able to see that and hear me? Okay. So hi, I'm excited to see all of you again. And Dr. Brewer, since you were not at the defense of the proposal defense, I'm going to recap a few things, especially for you, so that you catch up with the rest of us. And I just am very excited to tell you about the results of the Scholarly Project. You know, just as a recap, my project utilized the Iowa model for introducing evidence-based medicine into practice. This framework, it allowed me to evaluate the barriers that prevented post-stroke depression screening from occurring routinely on patients seen in one outpatient clinic in Florida. The clinic of focus specializes in hospital follow-ups for patients treated recently for acute stroke. And so today I'm going to remind you about the barriers I was prepared to overcome. I'm going to tell you about some barriers I did not anticipate, and finally, how they were mitigated to complete a successful educational module for clinic providers, as well as a 6-week pilot of depression screening for patients. So let's quickly review the scope of the problem. There is a known association between stroke and depression. This was really first identified in controlled studies way back in the 1970s, but had actually been a recognized association for over a century. The correlation has been well studied, and conservative estimates predict that about 30% of all stroke patients will suffer from post-stroke depression. So what we think about depression, you know, it's just not an unexpected sequela of any disabling illness. However, you know, studies that compare depression and stroke patients with similarly disabled patients with orthopedic issues found depression more prevalent within the stroke population. And the theory behind this is it's believed to be caused by a cascade of pathophysiological changes that occur in the brain in the weeks, months, and even years following a stroke. So just how does PSD affect stroke recovery and recurrence? Well, again, it's expected to affect about 1/3 of stroke survivors. It's associated with an increase in all-cause mortality, more frequent subsequent hospitalizations, longer hospital stays, decreased adherence to lifestyle modification and medication regimens, and so therefore an elevated risk of recurrent stroke. Swartz and some fellow researchers discovered way back in 2016 that the rates of diagnosis of post-stroke depression identified in routine practice were really only about 5%. So just kind of in the normal outpatient population, 5% of these patients were being picked up. And that's much, much lower than the 30% found in other repeated studies looking for screening for PSD. And it suggests that many active PSD patients remain undiagnosed. So the goal of a DNP prepared nurse is overseeing the movement of existing evidence into actual clinical practice. And for this, a spirit of inquiry is required. How could our clinic help improve the identification of patients suffering from depression following a stroke? The most obvious answer seemed to be to start some routine screening. And so the Iowa model for evidence-based practice was used as a framework to guide the project. And then the Iowa model is fairly elaborate, so we'll just review some of the major points. The Iowa model revised was created in a response to the challenges of translating research into real-world clinical practice. And it was felt to be a good fit to guide this possible implementation of routine depression screening in the outpatient stroke clinic. So the major steps of the project following the Iowa model were first, identification of a problem or trigger. In this case, there were guidelines for depression screening that we were just not able to follow. Then the next step is a team was formed and was spearheaded by me, a DNP student. And then research on depression screening following stroke was conducted using a PICO question. So you all recall that the purpose of a PICO question is to help refine search terms and narrow the focus of the literature review to just get the very best evidence available. Research was synthesized and evaluated by the DNP student in order to make some research-based recommendations to the team. So each research study and/or article was evaluated using the Johns Hopkins nursing-based practice model. And we went over this in more detail, Dr. Brewer, in the proposal defense, but I'm just kind of recapping here. And then we used guidelines. So we used the Agree To tool, appraisal of guidelines research and evaluation tool, to look at the guidelines from the American Stroke Association on caring for ischemic stroke patients. The team then did agree that research supported the use of routine depression screening in the clinic. And they also agreed that research supported the use of the PHQ-9 as the most appropriate screening tool. And so a pilot project was the next step of the Iowa model. But before that could be done, the DNP student and team needed to identify the barriers and facilitators to screening within the clinic so that this pilot could actually be successful. So although research, including the guidelines, were pretty clear, that PSD screening was recommended, there were still several barriers to address. And I just want to point out that these barriers are common across stroke follow-up clinics and neurology offices and just outpatient primary care across the country. This was not unique to our clinic. The barriers are diverse, but they include a lack of knowledge, some busy outpatient office schedules, limited training and financial resources. This is a big one. No validated screening tool for specific use with stroke patients, and really an unclear pathway for those that do screen positive for depression, and some concern about the level of evidence for depression treatment. All in all, the main barriers for our clinic were identified as awareness, efficiency. It's a busy clinic, busy program, and really finding the most appropriate screening tool. So luckily, where we have barriers, we have some facilitators. And so the facilitators for the implementation of evidence-based practice included just a wonderful team. We have a wonderful group of nurse practitioners and a nurse who provide the follow-up care in the outpatient clinic. These are all dynamic individuals and really represent early innovators of change. Everyone on the team just wants to do the best for patients. The setting was primarily a facilitator. It's a clean, well-organized office suite. It's on the campus of the hospital. It's easy to access. The majority of the 1,000 patients that are seen for stroke at the adjacent hospital, they're referred to this clinic as part of their follow-up care. Most of the patients, I would say, almost 100% of them are typically seen within 3 months of discharge, depending along rehab. And the patients in the office are cared for by one office RN who stays there in the office, and the 4 advanced practice nurses who rotate outpatient stroke clinic days and juggle this with their acute stroke response duties as well. So we have some stakeholders. These were also considered to be facilitators. There's an excellent team of 3 neurologists who are primarily in the hospital. One of those is the stroke director who oversees the advanced practice providers in the clinic. And at the time of the proposal, the office administration was also considered to be a facilitator of this project and a champion of evidence-based medicine. Well, administration changes and facilitators change and can become barriers in any project. And so fortunately, our Iowa model had a built-in feedback loop for just this type of unanticipated change. Let's go back to the first barrier that needed to be addressed. And that was the selection of an appropriate screening tool. The PHQ-9 ultimately was selected, and it had multiple reasons for this. First, it was widely used to identify depression in the post-stroke population. Several studies looked at the sensitivity and specificity, found it to be between 51 and 100% sensitive and 63 and 97% specific. But most studies finding, and some of those 51 and 63 were outliers, but most studies finding acceptable greater than 80% sensitivity and specificity when looking at psychometric properties. And that is just specific to the post-stroke population. Additionally, eCliniWorks is the electronic health record platform that the clinic uses, and it has the PHQ-9 actually built into the drop-down menu. So this is easy for the office nurse to administer and easy for the clinicians to review at any time, either during the patient visit, prior to the patient visit, or later on finishing up notes and making recommendations. The second barrier that was addressed was office efficiency. And so a few additional things about the PHQ-9 is it's brief, it's just 9 questions. It does not require any formal training to use, and it's free, which is also exciting. The RN at the outpatient clinic did have some experience with the PHQ-9. They were rotating, the office RN, specifically the stroke RN, was rotating to the affiliated psychiatric clinic and using the PHQ-9 there. And in consultation with her, she really thought that this process could easily be completed during patient rooming, and she was going to verbally relay the responses to the providers. And then again, they could look at that at any time. Okay, so now it's time for action, right? Well, before we talk about project implementation, let's recap, and we're going to use the steps of the Iowa model. So the outpatient clinic was not completing depression screening on stroke patients as part of routine follow-up care. And since this was part of ischemic stroke guidelines, the lack of screening was identified as a problem, creating a trigger for the formation of a team and some review of literature. The evidence did support the need to screen for depression post-stroke. And in addition, we found that it supported the use of the PHQ-9, and it overcame the barrier of the appropriate tool. The concern regarding office efficiency was also addressed by having the office RN complete the screening during patient rooming. Well, there was still the third barrier to address, which was lack of post-stroke depression awareness. And so the stroke team RN and the 4 APRNs would be invited to participate in a short educational module. This consisted of a knowledge-based survey, followed by an 8-minute video detailing the incidence, prevalence, and risks of post-stroke depression. This video was followed by an identical survey and was scheduled to be made available 4 weeks prior to the planned pilot. A follow-up survey to assess the provider's perceptions of the pilot and their utilization of the PHQ-9 was also planned. On November 5th, 2021, the clouds parted and angels sang, and the University of Tennessee Institutional Review Board said that this was not a project that required IRB review, did not meet the definitions of research as defined by federal regulations. And so this cleared the way for the pilot project to begin. Invitations to participate in the educational module were sent to the nurses in mid-November, with 4 of the 5 completing the education and the surveys by the end of January of 2022. The 6-week pilot was planned to begin on February 7th, 2022, with the goal of screening all eligible patients over the age of 18 without a diagnosis of aphasia in the outpatient clinic. The original plan did involve comparing this group of patients screened with a group of patients from the 6 weeks, the same 6 weeks from the year before. And so the purpose of that was really to analyze their demographic data and any mental health concerns that had been discussed with the provider. So looking really at the body, the text of the notes to look for discussions about anxiety and depression that may have been carried out without a formal screen. But just before the implementation of the pilot, our beloved office manager, she took a well-deserved promotion. And so the interim office manager just did not feel comfortable authorizing the review of patient records by myself, the DNP student, either for a baseline comparison or for all of the descriptive statistics of the pilot population. Those football fans of you might notice that this is a Gator player taking out a Tennessee ball temporarily. So what we did end up doing was the office RN really just stepped up, and she offered to gather some data since they were not comfortable with me coming in and looking at the office notes. And Ultimately, they agreed on releasing the number of patients screened, patient age, their PHQ-9 scores, and the approximate dates of service. And this information was collected and in congregate, it just wasn't considered protected health information. It didn't have enough identifying factors. And I'm sure that's why they came up with what they were willing to release. It was kept on patient logs and updated by the office nurse, who then transferred it as a list to me via email. So after a gathering up and a dusting off, the pilot project to screen the patients for depression with the PHQ-9 began. And so now we get to look at the results. So paired sample t-tests were used to compare data from the pre and post video surveys. The small sample size did really limit the findings, but no statistical difference was found between the surveys. There were 4 knowledge-based questions posed to the nurses before and after the educational video. So all of them were aware that post-stroke depression screening was recommended by the American Stroke Association, and that the PHQ-9 did not require any formal training. There was no agreement, even after the video, on the percentage of patients that are expected to suffer from post-stroke depression. And the real conundrum appeared to be whether or not there was a consensus on the timing and the screening tools used to evaluate for post-stroke depression, with half of the respondents stating yes initially, and then a different 3 of 4 correctly responding that no following the video. More interestingly, the 5th question, which was asked the nurses to rate their own knowledge of post-stroke depression before and after the video, didn't change one bit. And so one reason I find this interesting is the post-pilot survey findings, which we'll come back to in a few minutes. Okay, I'm going to say this, hopefully, the statistical package for the social sciences software, SPSS version 28, was utilized to create a display of some descriptive statistics. Overall, 45 patients were found to be eligible for screening, and 100% of these patients were screened, and no one declined screening. So that's fantastic participation. The patients ranged in age from 23 to 100. So we had a wide variety of patients there. And so here on this screen, we're going to actually look at the scores from the PHQ-9. The scores on the PHQ-9 that are in the range of 10 or higher. And so I don't know if you can see over here, these are the ranges of scores 0 to 4, 5 to 9, 10 to 14. So these are the ones that are concerning. And then over here, we want to look at those that are in the range of 10 or higher. These are felt to represent patients that really need to be referred for further evaluation. So during the 6-week pilot, 17.8% of patients fell into this range. And if we think about that study that we talked about earlier from Swartz in 2016, they were finding that only 5% of patients were recognized in outpatient care. And then research is expecting us to find fully 30%. And here we found really almost 18% of patients. And so this falls in line with previous research that we were not picking up as many potentially depressed patients as we could have. There was really no statistical difference found in the scores between the younger half of the respondents versus the older. However, in the patients, the very old, the patients 85 to 100, 33% did fall into the range of scores of clinical concern. This was limited because there were only 6 patients in this group. And so when compared to patients at the lowest age range, and remember that lowest one was even 23, so a very young patient, there were 7 in that group. They only had a 13% likelihood of having concerning scores on the PHQ-9. Again, in consultation with our statistician, we felt that these sample sizes were too small to really draw any major conclusions, but it's something to look at in the future. Addition to, it may be important to look at age in addition to some things we were not able to evaluate, such as modified Rankin score, comorbidities, caregiver status. And for those of you not familiar with the modified Rankin score, it's sort of looking at independence and the ability to carry out activities of daily living. And that is something that is used often pre and post stroke to determine the severity of stroke. So this was my favorite part of the project. This was the post-pilot survey. This after, so the office nurse and the 4 APRNs have completed the pre and post education survey. They've completed the education module, and they've completed the pilot for 6 weeks. I was actually able to go to Florida for spring break and met with the office nurse and my wonderful community member who's here and in person. And then I just had some nice telephone interaction with the other advanced practice providers. And everyone was really positive. I was kind of overjoyed. I talked with Dr. Morgan afterward and was really thrilled. There was a consistent message that this project was helpful. They were going to continue using the PHQ-9 in clinic, and several patients had been referred on for further psychiatric care or started on antidepressive treatment. But did the data actually support this sentiment? So 5 post-pilot questions were posed to the office nurse and the 3 advanced practice providers who completed the initial education. The range of answers varied, but the means fell somewhere between somewhat agree and agree, or agree and strongly agree. So going back to the pre-post education test, when the nurses were asked about their knowledge of post-stroke depression, it didn't change at all before or after the video. However, question 5, following the screening pilot and in its entirety, had a mean of 9. So here the data supports that following both the educational module and the pilot, where they got to actually use the PHQ-9 in clinical practice, it did in fact have a positive effect on at least their perceived knowledge of post-stroke depression. So routine screening for post-stroke depression, is recommended by the American Stroke Association, and at our outpatient clinic, like so many others, we were just not able to follow this research-based guideline. By working as a team and utilizing a framework for introducing EBM, evidence-based medicine into practice, we really did have a successful pilot. Data from the pilot demonstrated that the PHQ-9 was an efficient and cost-effective screening tool. Almost 18% of those 45 patients screened in the clinic were found to be in need of further evaluation for depression. And so while there was no baseline data for comparison, provider perception really did support that screening was a worthwhile endeavor, and really was important within the context of optimizing the recovery of stroke patients, and that they would endorse the continued use of the PHQ-9 in clinic. It is possible that advanced age had a positive correlation with this, with significant screening scores, but this is an area for further evaluation. Our small sample size of nurses, providers, and patients really prevents us from making any wider assumptions. It's also important to recognize that no patient in this group declined screening, but patient autonomy needs to be respected, and that requiring permission from patients to continue the screening will be important. Also, screening is not a diagnosis, and this project really did not include the diagnosis and or treatment of depression. And so that is really outside the parameters of that. So this screening is just used to identify patients that may need further evaluation for depression. Ultimately, this project was unable to be completed as planned, but this happens. And so utilizing a flexible framework and capitalizing on the remaining facilitators really allowed this project to move forward. I really am heartened that the experiential data from the providers supported that the hypothesis that more patients are recognized with potential depression using a formal screening tool than without. The goal of the project was to implement quality guideline-based recommendations, and that was a success. So many future DNP students and champions of evidence-based medicine everywhere may benefit from my experience. This could be in the form of social media, in addition to my already created YouTube channel, any local conferences. I also would be proud to detail this journey as part of a journal article or a poster presentation. And there is much to learn from a well-planned project not going quite as planned. So this presentation has reviewed the many efforts that have been undertaken to provide the greatest opportunity for a routine depression screening of stroke patients to be sustainable adoption of evidence-based practice change in this clinic. And I'm really so pleased with the providers' responses to the education module, pilot, and surveys. The implication from the patient data is that screening really was a critical step in recognizing the need for additional evaluation of possible depression. The plan for continuing to use the PHQ-9 in routine practice shows that evidence-based medicine has been successfully implemented and that patient care most likely will improve. And I sincerely hope that you agree with me that this project has been carefully constructed, thoroughly evaluated, and well explained. And I also hope you think that this is a worthwhile project to demonstrate the expertise gained within the DNP curricula, just to highlight that transition of research into clinical practice, recognizing also that the patients here are the real winners. Thank you.
Yeah, why don't you, you had some other slides, or was it the end after references?
Well, I had some other slides in there, but that was a recommendation made to me in case someone had a question.
Okay.
That I could have those handy to go back to. Some of them were from the proposal and just some extra information.
Perfect.
I wrote questions down and then by the end you had answered them all. So that's good.
Yay.
The only thing I do have a question is the sample size, and you probably said it, and I was having printer dysfunction problems to my right. But anyway, was how many nurses and providers were participated in the education piece?
So 4 nurse practitioners and 1 nurse was invited. Okay. 3 nurse practitioners and the office nurse participated.
So 4 people. Okay. Mm-hmm. So, and I don't want to get into the weeds and you're not going to know the answer. So well, you may know the answer. I'm not sure. But is there a reason with that small of number why Carrie ran means and tested mean differences instead of median differences, like doing it non-parametric?
I don't know the answer why she chose to do that. I think we were partially, we had come up with a fairly detailed plan and then that plan sort of went off. So I think she was kind of scrambling maybe to make the post-pilot survey have more relevance to the patient data, but I don't know that really explains why she would pick mean over median.
Yeah, I just wondered because with that small of a group, I just was wondering, and like I said, I didn't think you'd know the answer. Not that you're not intelligent enough to know the answer. That's not what I mean by that at all. It's just that's just a question that I'm just wondering myself, since I work with Carrie about once a week. So anyway, but nice job. Congratulations.
Thank you. Thanks. I can't tell you how good it felt to know that it kind of really worked too. I know that sounds crazy, but it was like all that effort and they're going to, they like Sally Field. If you're old enough to remember, they like it. They really, really like it.
Are you coming to on-site?
Yes.
Okay. What are you, and this was why I was trying to get my printer to work. And this is so off the cuff and so probably not professional, but Erin can just tell them I'm not professional and that's fine. So what are you doing on Monday around 1:15?